Okay, welcome everybody to the part 2 of the Preparing for SJT series. As per usual, we have our SJT expert, Dr. Josie Elliot. So she'll be taking you through the slides, the teaching today. Feel free to ask her any questions. We'll have polls ready as well. So I'll let Josie take the stage.
Thanks so much. Thanks, Janice. I'm not an expert, but I'm going to try my best to help. So this is our final year series team. You saw all their amazing work they've been doing behind the scenes. This is one of our sponsors, Wesleyan, who have been very generous in sponsoring these events. And we also have, and then just going on to myself, I'm a FY2 doctor at Imperial College London NHS Trust with an interest in paediatrics. This is where I studied at UCL and I did my master's at Oxford. And the reason that I've been asked to speak to you is because I scored in the top 5% for the SJT. But as I said in the first talk, there is a fair bit of a lot of people say there's a lot of luck behind doing one in the SJT, but I think there are quite a few things that you can train yourself to do well in, and hopefully this talk will help with that. Okay, so today's webinar is going to cover a lot. We've taken on the feedback from last time, which was that people wanted more questions. So we've got 10 questions today for you to work through, taken from the official practice papers, because as I said in the first talk, it's best that we stick to the official resources rather than try and make up reasoning for our own questions, because that could be confusing. It's better to try and get a good understanding of the official papers. So you can see this is what we're going to cover. Also from the first talk, some people said, I think one person said to go a bit faster and one person said to go a bit slower. So I think we'll roughly stay at the same pace, just because 2 people out of 100 feedback isn't bad. And we can't please everyone. But if you do feel like we're going too fast or too slow, just put it in the chat and Janice will flag it. So without further ado, we'll start on our first question. Okay, amazing. So 56% of people have gone for B, C, D, E, A, and then we've had a handful of people go for C, B, A, E, D. Just also explaining there was some feedback if we could try and have people select different options by itself, but the platforms that we use, and pretty much any platform doesn't allow that. So we've stuck to what we can do. So it's not perfectly the same as your SJT exam will be, where you pick each option by itself. Anyway, really well done. So the answer is B, C, D, E, A. So we'll just go through it. So this is a situation where you've got to hand over jobs, and the normal format is you hand over your jobs to the F1 or maybe the SHO, depending on the job, who's going to be taking over for the evening. It is their job to take over these jobs that need to be done overnight. So the first thing to do is to explain to Gerard that it is his job to do these jobs, and therefore he should not be refusing. That's the best thing to do. Second best thing would be find another colleague to hand over to, but it's not another colleague's responsibility to do Gerard's jobs. He should do his own jobs that are his to do. So that's the second best option to do. Leaving instructions in patient's notes, you might think is an okay option, but in the evening, people are not going to be going through patient's notes. They'll be very busy and they've got a list of jobs that they've been handed over to do. So that doesn't ensure that jobs are going to be done. It's also not nurses' responsibility to do doctors' jobs. So you should never hand over to a nurse in SJT land. And staying on the ward for an additional 4 hours is unsafe. It means you'll be tired the next day and that affects patient safety. So definitely not any answer that says staying late beyond reason, beyond say 30 minutes max, is not going to be the correct answer. So the key themes here are patient safety and showing assertiveness. So I thought I'd just go through some principles for this theme of handing over jobs. In SJT land, the main things are hand over to your equivalent rank, i.e. the FY1. Do not hand over to nurses. Avoid handing over to a doctor who's not responsible for those patients, because they've got their own jobs to do and you need someone who is responsible for them. And don't stay late at work. So I've gone through both practice papers, and these are other examples that look at handing over jobs, you can see below. Okay, so well done. We'll start to see if there's any questions about that. Yeah. Okay, really good. We'll stop the poll there because that is 90 seconds. So really, really well done. 43% went for EFG. and 43% went for DEF. And the correct answer is EFG, which I can see about almost half of you went for. So really well done. This question is one of those where you have to have all three components to make what would be a perfect answer. And this question addresses the theme of handling patient or relatives' complaints. So we'll go through it. So the first one is to find out why was a medication not given, because there might be a very good reason. It might be, say, the patient's blood pressure is low, so we don't want to give the blood pressure, which is going to make it blood pressure medication, which will make it even lower. So first of all, find out why it's not given. It might actually be in the patient's best interest. It's just that people have forgotten to tell the patient. And also, it's good to remember that it's probably not the nurse's fault that the patient hasn't had the medications, because only doctors can prescribe medications, or certain advanced nurse practitioners. So it might well be the doctor's fault for not prescribing it rather than the nurses for not giving it. Second part, and this comes up in a lot of questions as the right answer, or one of the top things to do, is acknowledging a patient's concerns. If they don't feel listened to, then they're not going to be too happy. And then finally, arrange for the medications to be given. That's only correct in this answer because you're taking it in the context of the first of E, which is making sure that why the medications were not given. So as long as we know that there's no good reason for them not to be given, then we know that they should be given. So those three answers together make a perfect answer. And sort of general principles for handling complaints, because you can see here there are a lot of example questions in practice paper 1 and 2, looking at handling complaints from patients and relatives. And so I put down some sort of key themes that come out of these example questions, and they are: do not blame other colleagues. You can apologise for an institution without accepting blame. You cannot apologise for a colleague without their permission. For example, if you apologised here because if you apologised on the nurse's behalf, it's sort of blaming the nurse, and the nurse might not have done anything wrong. Don't feel bullied by patient relatives. There's quite a few questions in the practice paper where it says patient X's daughter is a lawyer. Don't feel that shouldn't affect your judgment in any way. We treat all patients equally, which is the next point. Do not lie to patients or relatives, or anyone really. It's good to have a chaperone when dealing with upset patients and relatives, and that comes from the GMC advice as well. And then in general, in any SJT questions, do not make inflammatory or confrontational comments. There's one which says something like, I cannot talk to you until you calm down. That's a very inflammatory comment and will not help the situation. So in general, avoid those. There's sometimes in the SJT questions it says, what would be the best response? And you don't want to have anything that would just make things worse. Okay, hopefully that all makes sense. Why would D be wrong? Okay, look. B, raise Miss Saeed's complaint with the nurse in charge. So it sort of assumes that the nurse has done something wrong. And as I said, the nurse might not have done anything wrong, because it might be that the doctor hasn't prescribed the medication. So going to speak to the nurse in charge is not really the best option here. It's better to find out why was the medication not given. Hopefully that makes sense. Okay, we will move on to question 3. So really well done. 90% have gone for CDAEB, which is the correct answer. So really well done, guys. It's good to see that you know about patient confidentiality, and that is a key issue in SJT land. So really well done. We'll just go for it quickly anyway, for the sake of making sure everyone understands it. So first of all, patient confidentiality is a top issue. As a nurse, she knows about patient confidentiality, and therefore she should know better than asking you to breach that. She may even be testing you. So it's important to politely explain that you cannot tell her due to patient confidentiality. Very good. The next would be advise that she wait until the meeting. She's got a meeting coming up with her mother and the consultant where it will all be answered, and it's only a few hours. Explore her anxiety normally would be a helpful thing to do, but in this case, you might accidentally give away some information which would risk patient confidentiality. So in this case, it's not important to do that. The next thing is ask whether she has permission. It's not a good thing to do because it won't affect the outcome. You still need to hear that permission directly from the patient, not her saying that she's got that permission. And then finally, breaching confidentiality is a big no-no. So well done. I put down some general principles from SJT questions on confidentiality, and those are: do not share beyond the necessary medical team without the patient's explicit consent. Do not take home any confidential information. There's some examples in the question papers of going to parties or finding it on, I think there's one where you find it on the road, somewhere there's confidential information on computer screens. These are all breaching confidentiality. So you need to remove and destroy any patient-sensitive information found in inappropriate places. And then also you need to inform patients of any confidentiality breaches that might concern them. It's often more important in SJT land to first destroy anything that breaches confidentiality and then tell the patient so that you're getting rid of the immediate risk. Okay, question 4. People querying the question. It might be a very similar one. We'll go through the principles of it and then I'll come back to the question. So, sorry about that. So, working within your competencies. These are sort of key principles for any questions on working within your competencies. So the main thing is, if you're asked to do a job that you're not confident in, is you need to explain to the person asking you that you do not feel confident, because even practicing with them supervising you is still a probity issue. You need to explain that you're not confident. The next thing is asking the person to provide instructions and supervise you. That's a low risk and safe environment for you to learn, unless the procedure is part of your undergraduate competencies, things like doing ABGs, cannulas, things that you are technically competent to do, in which case you could say, oh, it's my first time doing it as a doctor, would you mind if I attempted under supervision? And only in that case would it be acceptable for you to say, I'll attempt under supervision rather than first observing, because you are technically competent. Number 3 would be asking if you can observe. That seems like a sensible thing to do, but it's not it's not being fully honest. You need to say why you'd like to observe. You need to say, I don't feel confident because I've never done it before, or I'm just not confident in doing this skill. Number 4 in SJT land is try to avoid losing out on learning opportunities. So you would ask another FY1 if they would like to try. And then finally is to do the procedure to the best of your ability is very unsafe and absolutely not the right thing to do. I will go back through the slides and check the right answer for that, and before we send out slides, that's okay. But both questions have the same principles of telling people that you can't do it and then following this proforma. Okay, we'll stop the poll there because we've got 100 responses. So this question is looking at how to help a struggling colleague, and really well done. Most people got the correct answer, ABE. So this one is talking about how can you best help her whilst acting within the remit of an FY1. So first of all, you can talk to her about what are the circumstances of her distress. The talking alone can be therapeutic and you can offer some insight from your perspective. But at the end of the day, you're not a counsellor, you're not a GP, and you're not a senior. You can't control whether she is allowed to come to work or is allowed to do certain procedures and so on. So talk to her about her distress is a compassionate thing to do. But in addition to that, she needs to speak to a senior, and you can offer to go with her to speak to her consultant or recommend that she speaks to her educational supervisor. In general, with these questions, things that they recommend not doing are do not suggest that she takes annual leave for ill health. Sick leave is different to annual leave, and you should not be using annual leave as sick leave. Offer to help with workload is not a beneficial thing for them because it just perpetuates their feeling of not coping and it makes the issue go on for longer than it needs to. Whereas if you just say, things are brought into perspective that she's not coping, she needs help, then it will help to stop that cycle. Don't speak to other people's educational supervisors. You encourage them to speak to their supervisor, or you speak to your own. You don't speak to someone else's. And then finally, supervising or telling an FY1 colleague what their clinical role is is not one an FY1 does. You shouldn't tell them what communication workshops to go to or what learning opportunities they should attend. It's only seniors who can do that. And then you can see practice questions that go through the similar themes just below as well. Okay, hopefully that makes sense. Sorry about the last question. Good, there's no questions, so we will carry on. Question 6. The answer is BGH. So we'll just go through it. So in general, this question is different to the last one because in the last one, you, well, in some situations, you have a situation where you've got a colleague who does something wrong, and we'll come on to some questions like that later on. Whereas this one is about advising a colleague who's come to you about something bad that another colleague has done. And you have to approach it quite differently to if you were directly involved. So main things are, if colleague 1 has a problem with colleague 2 or the other way around, you should suggest that they speak directly to each other. Try not to get involved because you don't know the full situation. You only know one side of the story. Advising colleague 1 to speak to a senior about their concerns is very appropriate. And if there's patient safety at risk, then they actually have a duty to do so. And then another key thing here is ask if there's any evidence of patient safety being compromised, as that makes the issue even more urgent. But in general, avoid acting as a third party. So the SJT is quite specific about how you do these questions. And that is that you do not want to get involved. In terms of acting remotely when you're asked for advice, it's about suggesting they speak to each other or speak to a senior. Do not try and get information on one side or the other. It's not your job to investigate. So really good. Hopefully that makes sense. Okay, so most people have gone for AEDBC and some people have gone for ADBCE. Really good. Well done, guys. So this question is all about requesting imaging, which is a theme, I think, unto itself, and quite valuable advice as an FY1 because you do a lot of this. So I thought helpful to go through. And as you can see, there are 3 practice questions on this as well. So the first thing to do is to speak directly to a person who has asked for the scan, i.e. your consultant has told you, we need this MRI, and you don't really understand why. This happens all the time. So as an FY1, you quite often are asked to order a CT. For example, on a fast-paced general surgery round, they say, order that CT. And then once the ward round's over and you finally can gather your thoughts, you realise, oh, hang on, I don't know why we need that CT. So always important to ask on the spot, what's the indication? Because when you request the scan, you have to write something like query abscess or query bowel perforation, or what is it that indicates a need for a CT scan in this person. So first of all, speak to the person who's asked for it. They know what they were thinking when they said ask for that scan. Second thing is asking the radiologist to consult your consultant to discuss. Not all radiologists will be willing to make time calling other doctors when really it should be your job to write it on the request form, and it will probably delay things if they've got a lot to do themselves to then also be doing your job. And the SJT reasons that it's not good for your learning if you're not involved in finding out why the scan was needed. Waiting until the afternoon ward round will delay what's been termed as an urgent scan, so that's not beneficial either. But the last 2 are worse, because the first one, politely explaining that the scan is urgent, will not get you anywhere. The radiologists have set criteria for why scans are needed. And for example, if you're asking for a CT chest abdo-pelvis in a young patient, that puts them at very high risk, well, not very high, but increased risk of cancer when they're older. So you've got to have a pretty good reason as to why you need it. And they're not just going to trust your judgment of, oh, but the consultant said it's needed. You need to say why. And then finally, asking any available doctor about how you do a scan is not going to be helpful because they won't know specifically why this scan is needed. Hopefully that makes sense. And it is really helpful advice as an F1 to know this. Okay, really well done, guys. Question 8, and then we'll have a little break for feedback. So 88% have gone for ADBEC. Really well done, guys. I've picked these questions because I think they're some of the harder ones. And so hopefully some learning points rather than just teaching what you already know. So handling colleagues' bad behaviour is how I've termed this theme, and there's quite a few questions that come up in the SJT. The answer for this one, completely right, as you all said, is A, D, B, E, C. And part of the reason I included this question is because the B and E can actually be either way round. So it's worth knowing that there might be an option when you're doing the exam paper where you can't choose between two answers, and actually it might be that they both might be in the same place. So don't get too worried if that does happen. So let's go through the answers. The first answer is to tell your colleague the truth. And it's a huge probity issue for you to lie to the police. You could probably lose your license for doing that. So you need to make it clear to your colleague that that's not something that's acceptable to do, and they should not be doing that either. Do not get involved in colleagues' lies. That's the D answer. And then B and E can be quite similar sort of answers. So explain to your colleague why it's wrong. You might think that might go higher up, but it's more important to be very clear that you are not going to be involved before you explain to your colleague why it's wrong, because they actually should already know, and they probably do know. So you explaining why it's wrong is not really affecting anything. Seeking advice from seniors would be the next thing. I think part of the reason why it's not put higher up here is because it doesn't directly deal with the situation, which is that your colleague has asked you to do something, you need to give an answer, and that answer is to say no. And finally, agreeing to go along, lying to the police is a very serious offence. So there are lots of questions dealing with colleagues' bad behaviours in both practice questions, as I have listed here. And so I put down some of the key learning points from these questions. And that is that it's not your place as an FY1 to initiate investigations or to help with financial concerns. That's another kind of question that comes up. Or to tell a consultant that their behaviour was inappropriate. Or to organise cover for a colleague that's running late. None of those things, if they come up in questions, none of them are your job to do, so don't rank them highly. You might have a situation where a consultant, for example, shouts at an F1. In those kind of situations, you want to be less confrontational because it's your consultant, for right or for wrong in SJT land. And it says things like, suggest to your consultant that the patient might have felt uncomfortable by their behaviour, rather than tell your consultant off. So that's kind of how you go about it in those situations. There's also, I think, 2 or 3 questions about drunk colleagues. This is slightly different in that this is a huge patient safety issue. So you need to be a bit more direct with these ones. So with those, you deal with the immediate patient issue risk. For example, there's an example of a registrar is about to, I think it's, maybe I'm getting slightly confused, but there's something like a registrar is about to perform surgery or about to review a patient. You need to say to the registrar, you are drunk and you cannot see this patient, rather than saying, I think you look a bit tired, maybe you get someone else to do it, because in those situations you need to be direct. If your consultant's not eaten and they're about to go into surgery, then you need to tell them you're worried about them performing surgery, because that is a huge patient issue as well. So rather than things in those situations, different to the ones where you see them shouting at a colleague or a consultant shouting at a colleague, where it says suggest and so on, then you need to be more direct. Hopefully that makes sense. So you can apologise on behalf of an organisation for any unnecessary distress. For example, a patient's surgery has been pushed back because another surgery is taking longer. Say, oh, I'm so sorry it's taking so long. But it's no one's fault there, and you definitely can't apologise on behalf of a colleague without their prior discussion and permission, because it looks like you're blaming a colleague. And anything that perpetuates a colleague's bad behaviour, such as offering to catch them up for being routinely late, offering to check their discharge summaries because they're not doing them very well, are generally not going to be ranked very highly either. So there's lots of questions in the practice papers which can kind of help you get to grips with this theme. Okay, really well done. We're coming up to the last 2 questions, and then I've put in some extra slides on themes that I think are quite helpful to read through. So next poll. Most of you have gone for E, A, B, C, D. Really well done. And that is the correct answer. So excellent. So this question, the kind of theme I was getting at is managing your own clinical mistake. So this is a sort of performer in general that's quite helpful. Actually, that's the next slide. But for this question in particular, the main thing is there's been a breach to patient confidentiality. And as we said earlier, anytime there's a breach to patient confidentiality, patients need to know. It doesn't necessarily have to be the first thing you do, because it depends on what is the biggest risk to patient safety. In this case, they coincide, because being able to contact the patient straight away and say, oh, sorry, I know that there's information on that letter you have which says that you should be taking this antibiotic every single day, or not taking this antibiotic every single day. And that's something maybe they should or should not be doing, but you've given them the wrong information. So you need to contact them urgently to make sure they're doing the right post-operative things, and also to tell them that you breached patient confidentiality. So this is kind of the perfect first answer. Then you let your consultant know, because with SJT questions, patient safety first, and then everything else. Seeking advice from a peer might be helpful, but it doesn't deal with the patient confidentiality, patient safety issue, and it's better to let your consultant know first. Absolutely, do not swap the letters without telling anyone, because that's forgery, and it also doesn't mean that the patient's going to get the right letter because it's already been sent out. So that's not a safe thing to do. And doing nothing is really unsafe, because then the patient's going to be following the wrong instructions, and you've got a probity issue on your hands because you haven't told anyone, and also patient confidentiality issue. So in general, doing nothing is often the worst thing to do. So some advice I'd give on managing your own mistakes are: correct any mistakes that risk patient safety urgently. Tell the patient, first of all...
Everybody to the rationale slide.
Sorry about that.
So let me check where people are cut off. Okay, so I think you were going through option C being the fourth one, and then I think it got cut off. But some of the students have already said C. I think why is C not worse? Assuming you properly amend the letters and explain the error rather than covering up.
Why is C not worse? Okay, yeah. Okay, see, adjusting the original letters. Yeah, it's a good point. I was a bit stuck on that one as well, as to why you would not put C as the worst one. But and D is the absolute worst one. So C is like you're doing something, you're adjusting the original letters so that at least when the healthcare professionals have their follow-up meeting, they'll be able to see the right information for the right patient and make sure that that happens. And it suggests that at least you're doing something to try and correct the mistake, but it is a probity issue because you should be talking to the patient directly. Whereas D, trusting that they follow up will be sorted, is doing nothing, and does nothing to help rectify the issue. So I do agree, it's not clear cut. But I think the reasoning is that at least with swapping the letters, you are trying to slightly make things better. Yeah, exactly. You've corrected it on the patient record. That's a really good point, Iona. So at least the GP will know what should be done. And one thing to mention is that GPs don't get the discharge letters straight away. They normally get sent to them a few days later. So you can edit your discharge letters, for a few hours or even days, a day or two afterwards, until the patient's taken off the system, essentially. Yeah, exactly. Hisham, I agree. It's something proactive rather than just ignoring the issue altogether. But it's not clear cut. They're both pretty awful things to do. Hopefully that makes sense. Okay, and we'll just go through. Janice, are you happy to put on the next slide? Thank you. If we are correcting things, we can't call it forgery and explanation. Yeah, it's true. I see it as forgery because you're essentially swapping them. You've made a mistake and you're not owning up to it. You're just hiding it. Mm-hmm. But you didn't call it forgery, so I suppose it's not. So just some themes for managing your own mistakes. There are a few questions in both practice papers which address this. There's more about managing colleagues' mistakes than your own mistakes, but I think it's important to look at. So correct any mistakes that risk patient safety urgently. That is the most important thing. So do that above anything else, even before telling the patient if necessary. So if a patient is about to have a medication that it's the wrong dose, then you need to speak to the nurse more urgently than you need to speak to the patient, if that makes sense. And then informing your consultant that you need to inform your consultant, but again, it might not be the first thing to do if patient safety is at risk. And finally, generally, do not do nothing, because you've made a mistake. You need to own up to it. You need to right the wrongs.
Yeah.
Okay. And then the next page is feedback. Really sorry about that question I messed up earlier, but hopefully going through the rationale, those kind of questions helped. And big thank you to our sponsors, MDU and Wesleyan. And yeah, it'd be really helpful to get some feedback. And please remember, we don't get, most of you have gone with CEDAB. Really well done, guys. So this answer, which some people want to, but is quite tricky. Sorry, yeah. So really well done, guys. Amazing. 58% of you have got the right answer, so really well done. I thought the theme that I wanted to go through here is team working. So we'll just go through the answers. The first one is that, and part of the reason why I thought this question was helpful to go through is that it talks about considerations and what do you think is the most, in what cases is it most important to consider each one of these points? Because some of them are important, but what is the most important? So the FY1 should not be talking to members of staff in that way. That is the most important consideration here. And you can't really have answer 2 without answer 1, because saying they should be made accountable for what? Accountable for 1, the fact that they should not be talking to members of staff in that way. The healthcare assistant should tell a senior, but they shouldn't have to even be in that situation because the FY1 shouldn't be talking to them. So that's the bigger issue. Accepting feedback is not the issue here. It's that the FY1 is being verbally abusive to other members of staff. And then finally, it is your responsibility to stop bullying in the workplace, and therefore saying it's not your responsibility is wrong, and therefore that answer comes last. But you guys, most of you got that correct, so I won't dwell on that too much. And if we go to the next slide. Team working, key points from the practice questions, of which there's quite a few in both papers, is that the SJT doesn't recommending telling on other colleagues. So, for example, there's a question about a blood test that your reg asks your colleague to do, and they're telling you off for not doing it because they've confused the 2 of you. It's not beneficial to then say, oh, it was my colleague you asked, blame them. You need to have the higher moral high ground here, and instead prioritizing doing the important test rather than telling on your friend or telling on your colleague. Okay, the next thing is avoid moving teams. If you've got a colleague who is bullying you or undermining you, because what you should really do is deal with the bullying issue itself rather than leaving it for another possible new member of the team to deal with it. If there is a job that a colleague hasn't done and you're capable, then check there's no contraindications for doing it and do it yourself. That's comes up quite a lot in the SJT as well. And then finally, it's unethical to take credit for other people's work. For example, there's some questions about research projects where you can't get in contact with the original author. Don't take credit for other people's work. That is a big no-no. Okay, so I just wanted to go through some themes that I think are quite helpful. There's only one question, so I didn't want to dwell on it too much, but translations are quite interesting because it isn't necessarily the order that you expect. In SJT land, first of all, you want to find a doctor who speaks the language. If you've got a patient who doesn't speak a language that you can speak, how do you deal with that? The SJT recommends, first of all, find a doctor who does speak that language. That's the best thing to do. Second best thing would be to get the NHS telephone translator service. And their reasoning is that the telephone service can take time, and it certainly can. I've been on hold to them like 20 or 30 minutes. So it does delay things. And you can get things, you don't get the sort of non-verbal communication as well there. Asking a senior on how to proceed would be the third thing to do, because it's not actually doing anything. It's seeking advice, which is helpful, but you should kind of know what to do because it's quite a common situation. Asking your patient's next of kin comes further down, although in reality we use it quite a lot. It can be a confidentiality issue if you don't have the patient's consent. And you don't know that the next of kin might have a vested interest in not necessarily relaying all of the issue. And then finally, continuing to try to communicate with the patient by yourself is not good clinical care, and it could be unsafe. So that's quite a helpful, hopefully, order for you to look at. And then if we go to the next slide, social media and professional boundaries comes up a fair bit, 4 questions in the practice papers. So I just wanted to put a slide on here to help you out. It's quite interesting because you think that if you got a friend request from a patient, you would just decline it and ignore it. But SJT actually recommends it's a better idea to send a message saying why it's inappropriate for you to accept it, to stop it happening again. So send a message declining it, and then the next best option would be to decline the request. Don't go to patients' parties. That comes up. Do not buy patients' presents. You have to treat all patients equally. The GMC says do not ask or accept presents from patients, relatives, or anyone that can be seen to affect the way you treat patients. And that's very open to interpretation. So in general, avoid accepting gifts. But NHS England gives a bit better advice, a bit clearer advice by saying don't accept any gift more than £50. You can accept on behalf of an organisation, but not for yourself. And you shouldn't encourage patients or relatives to donate to charities, because the GMC specifically says do not put pressure on patients or relatives to donate to charities. And then finally, GMC advises do not treat your own family or colleagues if you can avoid it. And then the last theme, I think it's the last theme that I wanted to go through, is just following hospital prescribing protocols. And there's a few examples where you have to follow a protocol, but you don't know what the protocol is. So, for example, you've got a patient who's going for surgery and you don't know what antibiotic to prescribe them. So, first of all, seek advice from a senior in your group, because they know the patient, they know what's normally prescribed, they know the protocol, they're the best person to speak to. And if it's antibiotics, the next best person to speak to would be the on-call microbiologist. But they're not as good as your senior because they don't know the patient, and you don't want to be asking them for routine queries. Next best would be BNF. Don't really ask nurses for prescribing advice. It's not technically their job. But surprisingly, SJT still ranks that higher than national guidelines. And their reasoning is that national guidelines on prescribing don't give you doses and they don't follow local policy. So it's normally the last option. And then some final things is don't ask for advice from colleagues who are not on duty. Don't wait until pre-surgery or too late to raise these issues if you have a chance to raise them earlier. And it's definitely not your job as an FY1 to cancel surgeries. That's something that a consultant should be deciding. So if that's ever an option, don't pick it. And I think that's our last slide.
Thank you, Josie. Really thank you for the talk. Hopefully this is helpful for everybody. We actually have upcoming talk to SJT by Dr. Elvin Garnett, who has a... actually, we have one more slide, Josie.
Oh, yeah. I put in some wording just for things that might be helpful.
Yeah. So I will just make sure we dwell on this slide for a little bit longer, because sometimes people might want to just take a quick photo because whilst they're waiting for the webinar. I'm moving on. Yes, so thank you so much, Josie. So we have Dr. Elvin Gardner, who has a master's degree in healthcare and law, and he will be covering top tips for answering medical legal questions in the SJT. So there will be questions around mental capacity assessment, and then about other more ethical and medical legal issues that Josie have not covered in her Brilliant 2 series. We also have upcoming webinar series, of course, in our PSA series, Prescribing for Safety Assessment tomorrow in medical emergencies. And then we have upcoming sessions on the final year series in medicine. So I will put the links here, but we would usually send out a newsletter to everybody. And also putting a link here for surgery series. Okay, and I will let Josie look at the questions for now. We're also recruiting final year and penultimate year medical students to be the representatives for our series. And we've already got some very awesome submissions, and I've put the link in the chat for your applications. So if I read the questions out for Josie as well, can you explain what you meant by be wary of assure on the last slide?
Yeah, of course. So I think there's one example in the practice papers which talks about a nurse comes to you and they say that they're worried about a patient, and it's a patient you reviewed about 4 hours ago, and they're saying, we're worried about this patient. Don't in that case be saying reassuring about a patient, saying, oh, I saw them 4 hours ago, they were fine, and assuming that they must be fine, because something might have happened in the last 4 hours, which means that they have clinically deteriorated and they need urgent care. So any option that says sort of reassure before actually gathering more information, it's not going to be a good option. Or for example, if you've got a patient who may or may not have cancer, again, avoid reassuring, because then they might come back to you later saying, you told me that I wouldn't have cancer, and you have no leg to stand on because you've given them false reassurances. So generally be very wary of words that say reassure, or yeah, exactly as Connor says, avoid things like promising things to patients because you might not be able to fulfill them.
Mm-hmm. Agreed. So let me check if there are other questions. Anyone has any other last minute questions that you want to ask Josie?
I can always reply to them on the chat later on if people want to.
Of course. Yeah.
I'm happy to. And you guys have all done amazingly. You're still, a month away from your SJT and you're doing really, really well. Really hard questions. Well done.
Oh, okay. A question. There's a question about a relative from Australia who wants to know about her father's condition in the practice papers, I presume.
Yeah, I think I do remember reading that. What is the question? Tam, what's your question about it? Yes, exactly, Sophie. So checking the BNF is ranked higher than asking the nurse in charge, but and national guidance comes last. So Tam, do you tell her no? So I don't know the exact question, so I'd have to check the wording, and that's quite important in the SJT. But in general, you would not give information to a relative over the phone without the patient's explicit consent. And the GMC says something along the lines of, if you have reason to believe that a relative would want to know that a patient is doing fairly okay and they don't have capacity, then you can say something like they're doing okay. Or if there's things like power of attorney, but it would have to depend on the exact wording of the question as to whether they had the patient's capacity, consent even. Is there an option to highlight questions? Yes, I think there is, but I can't remember. I'm not too sure. I might have changed. Any in the background, sorry. For antibiotics, do you prioritise the microbiologist in your hospital over the BNF? Because they will know the hospital's guidelines, and then BNF is next.